Thank you, Dr. Manessis, for being with us today. And you require no introduction, but I'll still give it for the benefit of our audience. So you are an endocrinologist specialist. You have years of experience, board specialized for obesity management as well, and you have your own practice in New York. And it's quite a busy practice, and we have been very lucky to kind of partner with you in trying to kind of see how a retinal biomarker that can predict cardiovascular risk can be implemented in clinical care pathways. Just a little bit about ManyWell. We are trying to create a new standard in preventive care. We are trying to leverage the retinal imaging to kind of measure the cardiovascular risk. We are trying to do it non-invasively. And our approach is to be proactive about early detection. We have multiple regulatory approvals, but right now we are under the FDA regulatory pathway. So we are still not approved in the US, but hopefully we can bring this product to the US soon as well. So I think, Dr. Manessis, my first question to you as an endocrinologist would be, you must be seeing a lot of diabetics, and diabetic retinopathy is something which is increasing over the years, especially as we are catching the diabetics at an earlier age, and they are undergoing treatment for long durations of time. How often do you see diabetic retinopathy first in your practice, and how often do you recommend retinal exams to your patients? And I would also ask, realistically, what's the compliance rate like, especially in your practice?
I would like to thank you, Dr. Fakour, and the medical who gave me this opportunity to talk about something that we've been doing in this office for a long time, actually. Hopefully, this discussion will reinforce the clinical practice of retinal eye exams in all primary care settings. So in terms of how often do we recommend retinal exams to our patients, being a diabetes center, we have thousands of diabetics. Okay, and a lot of the new patients who come in pretty much don't even know if they have any eye disease because they've never been examined, or the last time examined was years. And usually when we see them, that means the A1C is very high and they are uncontrolled. So doing a retina exam for those patients is a must. We try to do it to every new patient who comes in the office at the first visit. And the reason why we try to do it is we want to make sure they don't have any retinopathy, proliferative, of course, or non-proliferative. Okay, and if they have it, of course, we're going to force them to go to see a doctor, a retina specialist right away. And the other thing, the other reason why it's a good information to present to the patients about the retinal exam is that the fact they have eye disease. If they have eye disease, somebody is going to be willing and will be more proactive to do what? To take care of the diabetes as needed. And in terms of taking care of diabetes, it involves also a medical input, because if those patients are controlled and we need to start them on insulin or GLP-1 receptor agonists, and considering the fact that retinopathy can get worse when you start insulin or GLP-1 because of a rapid improvement in numbers, it's a very important information to have in case patients' medical the vision gets worse in the first couple of weeks of managing of a disease. So that's definitely one part. In terms of the compliance rate, the compliance rate is annually every diabetic should get an eye exam, a retina exam. Okay, the compliance rate is not good. Okay, I will say it's less than 50%. Maybe it's a little bit more in the literature. And the reason why that's the case is because patients do not go see the eye doctor. It's another visit. Okay, diabetes is not a issue that really gives them the chance to, they don't see the reality that this can, diabetes can cause eye disease and actual, subclinical. And, we have a lot of patients who come back in after the diabetes is well controlled, and they have not been followed up with the eye doctor, despite they were told to do it, despite they agreed to do it. And despite we try to figure out if they did it when they tell us they did it, because we cannot find a note that verifies that.
Yeah, I think I agree with you, Dr. Meneses. Probably, yeah, you highlighted two important components. One is the fragmentation of the care pathways, because again, all of our specialities they operate in silos. And the other one is, despite kind of knowing about the microvascular and macrovascular connection between the eye and again, major events that can occur because of findings in the eye, this has been something that has not been kind of utilized till now as a way of kind of following patients up for their systemic disease. And again, diabetics, they are screened. The guidelines, as you exactly mentioned, they tell that you should do it on annually basis. But again, a lot of times, especially for ophthalmologists in their busy practice, if it's just a non-proliferative disease, they don't care for it. And then they would sometimes even not tell the patient that they have that long-standing non-proliferative disease, because again, there's nothing that ophthalmologists can do. But again, considering how the newer medications are coming up, and we see even resolution of the non-proliferative diabetes in the early stages, especially with the GLP-1 drugs and some of the newer molecules that we have, I think it's quite an important component in their care pathways. I think that kind of leans into this as well. Dr. Meneses is routinely, while managing these patients with endocrine and metabolic disorders, and I'm sure you see a lot of them in the CKM continuum, especially now that the AHA has tried to bring together all these causes of the cardio, kidney, metabolic diseases under one umbrella. What are the tools that you routinely use to kind of estimate the cardiovascular risk for the patients that you see?
So this is an excellent question, because this is one of the most important questions we should ask the patients about what's, about the family history, because we already know that the majority are diabetics. We already know that may have hypertension, hyperlipidemia. But this is first the best measure or tool to use to measure cardiovascular risk is personal history, past history, and of course, family history. Okay, we know that diabetes it increases your risk 4 times more to get cerebrovascular disease, and it gives you a 2 to 4 times more higher risk of developing acute coronary syndrome or peripheral arterial disease. But we feel like even if we try to control the patients and we try to treat the A1C, treating a number does not mean that you are measuring cardiovascular risk or you taking care of that. So cardiovascular risk, the easiest thing that we can do is really, we can use a cardiovascular risk assessment from the American College of Cardiology, okay, to assess that. But again, this is a formulas that predict what we can do. We can calculate the 10-year risk in the future, but we really cannot use that as a way of knowing if you already have cardiovascular disease. Okay, so when you present that to the patient, then you will be able to understand what should be the target for blood pressure, what should be the target for the bad cholesterol, looking for any other cardiovascular factors, lipid factors like lipoprotein A, if the LDL is normal and still basis from family history. But living in an era where nobody wants to be on the statins because everybody feels they have side effects. That's because of the social media issues. Okay, I tell the patients, if you want me to tell you if you need it or not, or what dose you needed, a lower dose, intermediate dose, or the higher dose, you really need to know if you have heart disease. If we feel like you have heart disease, okay, we should be more looking at really intensifying your statin management, and everything else is for there's other medications if you have any issues. At the same time, depending on the risk that they have, of course, you can consider and stress the importance of lifestyle interventions, exercise, diet, okay, but as you have pointed out here in this slide, we should use those risk calculators for every type 2 diabetics, despite they're not the most accurate, and usually they are predictors for what's going to happen in 10 years. They don't say anything about what the patient has right now.
Yeah, I think you have kind of highlighted what's the main limitation of these calculators. One is that they cannot show what is happening right now, and I think another one, Dr. Meneses, what do you feel about the implementation part of these calculators? Because the newest one requires so many variables. Do busy clinics actually have the time to sit down and calculate these for every patient?
No, we don't have the time. And unfortunately, this cannot be done every time the patient comes in the clinic. It'll be nice if you do an initial cardiovascular risk calculator, use one of those cardiovascular risk calculators when you see your first person for the first time, because that's when you should ask the patients also about any macro or microvascular complications. Okay. At the same time, you should risk and assess, which we try to do. But no, there's no time to do all this more complicated models to help us get to do a more effective screening. What we have done in our office, we have created a certain screening recommendations. Okay, which patients we should screen. Okay, for cardiovascular disease, and it helps us goes to the risk calculator, and so we are more personalized our approach to patients who have a higher risk of developing cardiovascular risk, and it's not easy. No, that's for sure.
So I think that brings us to like the white elephant in the room. So when you kind of first heard about that, okay, a retinal image can help you measure cardiovascular risk, what was like your initial impression? I'm sure being an endocrinologist, you are like more attuned to the fact that diabetes affects the eye so much and that there may be a relationship between the retinal findings and the cardiovascular, again, systemic complications. But do you think, like, when you couple CVD risk assessment with a DR screening program and one single retinal image giving you much more information than what, again, a plain DR screening can do you think it can also kind of improve improvement and uptake across the stakeholders as well? So it's like a two-part question, I know, but I would just like to listen to your opinion about this.
Answering the second question, definitely, reinforces and really supports what we're doing about the eye exam. Okay, we do eye exams in every new patient who comes in as an initial assessment because we want to see if they have active proliferative or non-proliferative disease, so we can be a little bit more careful about the management and assess the patient and be able to advise what may happen. But using a simple fundus images to assess or help us decide if a patient has a cardiovascular risk, it's really out of a traditional way of practicing. Okay, we usually, those formulas using certain traditional risk markers, which we know, total cholesterol, HDL, history of smoking. But in the beginning, I said, I need to read about this. Okay, when I heard about this, because, and then, of course, after reading and seeing the data, okay, I thought this will be another very effective way of doing cardiovascular risk assessment. It's like using one stone, you can hit two birds here. You can get retinal information, and you also can get cardiovascular risk assessment. And it's interesting. My mid-level providers, they couldn't really figure out that we need to do a retinal exam for every new patient who comes in because our yield was very low. But guess what? After we introduced this cardiovascular perspective, okay, guess what? Everybody's doing it now, okay? Because now they can see and they can get information, they can translate that to their patients and be able to give them a more global, personal, but global way of how cardiometabolic disease it can affect their systems. So yeah, that's a big one.
I think you totally kind of highlighted what modern medicine is moving towards, and that's like towards a more personalized approach to every patient. Again, these guidelines, whenever they come, they are made on the basis of large amounts of data, but the individual patient who has walked into your clinic, I think personalizing the score and personalizing the risk for them, and especially refining the risk, This is such a critical measure. And if, again, as you highlighted, the staff is able to see that risk refinement happening in real time, I think that improves the acceptability, one. And second, kind of helps integrate into the workflow pathways better as well. I think now I would like to kind of let you take us through this case. I know this is a very interesting case that came in your clinic. Yeah, please tell us more about how you use the risk refinement aspect of the retinal biomarker to kind of see how this patient can be managed in your clinic.
This was actually a type 1 patient, if I remember correctly. Yes. Okay. Mid 50s, 58 years old guy with a history of type 1 diabetes, very well controlled for years, but of course, a chronic disease. Okay. That we started seeing a couple of years ago. And retinal exam based on the reports did not show any significant retinopathy. Okay. And we start, during one of the follow-ups, I start going through again, because I typically do that. I start asking any questions about micro or microvascular complications, heart disease. And he, this patient told me, oh, I have had stress test a couple of years ago, and it was perfectly fine. My cardiologist said it was good. So I said, you know what, let's do this cardiovascular risk assessment by looking at your arteries in the back of your eye, the retinal vessels. And when we did the Dr. Noon cardiovascular score, guess what? He ended up being a moderate risk patient. Okay. And he hadn't seen his cardiologist for years. The stress test was done years ago. So what I did is, you know what? Let's do this. Let's translate this information because, of course, saying that somebody has moderate risk, it can be, it's a quite, despite he was on elevated side of that moderate risk. Okay, our job was really to define better his anatomy. Okay, and I sent him to your cardiologist because he's 60, almost 60. So they definitely do a calcium score. And if you can see on the right side of the image, okay, he had a very high calcium score. Okay, he didn't have obstructive disease. Okay, but he definitely had a extreme high calcium burden with mild stenosis, but it was diffuse. Okay, so guess what? He definitely has coronary artery disease, and we definitely need to aim for better management of his sugars. A1C is as good as it can be. We decided to, of course, make him intensify his statin treatment. Okay, and really figure out how we can manage and monitor better in terms of cardiovascular risk. And guess what? The patient was very appreciative about the information he got. Why? Because now he knows that this is real. He knows that he has the disease, and then he needs to work a little bit harder together with the help of the providers, medical providers, to be able to redefine his true cardiovascular risk, because it's much higher compared before we did calculated Dr. Noon CVD score.
Yeah, I think that's a very, very important component that you highlight. And what I would like to ask here is approximately what is the proportion of patients like these in your clinic? I understand this was a type 1 diabetic patient. And again, the type 1 diabetes we know is much lesser than type 2 diabetes. But if you could tell us a little bit more about people falling in the similar background, again, well followed diabetes over time, but may not have a single risk factor, one risk enhancer, probably a family history, probably a stress echo, probably kind of angina, but not angina, don't know whether they have it. What's the proportion of patients usually seen in an endocrinologist practice that fit this kind of a profile, which is not very clear cut, whether they need statins, not very clear cut, whether they even need, say, for example, a coronary artery calcium? So what is the approximate percent of proportion or the type of population that falls into this kind of profile?
Okay, so there's, of course, a bias to which patients you will screen. Okay, about 55, male, chronic disease, but definitely we see in that age group, we do see a lot of moderate risk patients. Okay. And when we see that, the majority of the patients are actually moderate risk. Okay. Not everybody has such an extreme calcium burden. Okay. But the moderate risk patients, we refer them to see a cardiologist. Okay. We refer them to see a cardiologist who will confirm or not, because there's a lot of cardiologists who don't believe still preventive medicine. We do stress tests without an echo. So I just feel like this type of angiography is a eye-opening, and a lot of my patients have moderate risk. I will say at that age, about 50, 55, I would say about 30 to 40%. We can look at the data and see a little bit more now that you stated that. But I just feel like it's about 40%. Okay. There's some patients who have low risk, and usually are patients who are simple diabetics. There are, you have to, it's not only the calcium burden here, but also what's critical is the disease time burden, how long you have a disease. And we're reaching a point now that we have a big rise of the incidence of diabetes at an early age, adolescence, even before 15s. So we have to expect that people will have type 2 diabetes, for example, for a longer period of time. Yes, type 1, it's a lifetime diagnosis, but in the type 1 population is also critical to know if they have disease. Why? Because we are a little bit more relaxed about targets, LDL targets. Guess what? Type 1s can get atherosclerotic cardiovascular disease. It is happening to those people. Type 2s can be more silent because of not silent disease. It's silent because we really do not screen. But definitely with this increased disease burden, okay, or exposure, I would say time exposure to disease, we're definitely going to see more and more of this as years progress at a much younger age.
Yeah, I think you correctly point out that because the burden of atherosclerosis starts very, very early, and especially as you just mentioned, we are seeing events happen much earlier as the populations are getting more older before they die. We are having these cardiovascular events at a much earlier age. So, young MI was something which was not very common, say about 20, 30 years ago. But again, young MI has become so common that now they have like separate registries for that. So I think totally kind of how the population, the demographic shift is happening, having a tool that can early stratify risk, being non-invasive, and also kind of adding to one of the tools that is available to physicians like you who see high volumes of these patients coming in can be a very beneficial uh, thing for the patients, I guess. I think at this point of time, probably I would also like to ask you, uh, for example, if the routine care pathway, dropouts do you usually see? Say, for example, if this patient walked in and the retinal scan was not available, and you would send someone for a CT scan, do like 100% of the patients go for the scans, or do you feel that there is a significant dropout again because of the cost considerations, because of probably again how their insurance plans may be? Or do you feel like if you refer them, they are definitely going to get the scan done and come back to you? Do you think there is a potential of dropout aspect that also can be kind of addressed? Because now they know their retinal risk, so it will be an additional component that kind of motivates them to actually get things done.
This retina biomarker as a risk refinement tool, it definitely it's an extra incentive for the patients to go to the test. And guess what? They're going to go to it like this patient. Okay, look at the dates. January 2020, he had this, and February he had the CAT scan done. Okay, not only he went to cardiac, but he had the calcium score. Of course, it will send calcium scores if we try to do a calcium score. Yes, the patients will go, but I reinforce this with a very simple test like the Dr. Noon CVD score, because it gives them, they see the moderate risk or the high risk sometimes, okay? Okay. And I explained to them the retina images can reflect to what's going on in the coronary arteries. So, if you see moderate or high risk, guess what? You need to go assess yourself more, extensively with a better test. Okay. And they do it. I will say the majority of the patients, almost all of them, go do it.
Yeah, I think that's quite good for people like us to know that the tool actually helps in that motivation to kind of let the patients manage their risk better in a way and get the essential tests done, which are then recommended by physicians like you. So I think overall, when we look at some of the key takeaways, and you have been one of the early adopters who has adopted it for research use in the US, what do you think are some of the missing things which are probably required before this becomes like mainstream essential component of clinical care pathways? As an ophthalmologist, I would want to make the retinal camera as ubiquitous as a stethoscope. I would want everyone to have it. But what do you feel is missing? What do you feel is required before something like that happens?
I think the first thing is you need to think outside the box. Okay, it's not like A1C is high or low. This is what we're going to do. Goodbye. See, you have to think outside the box, and you have to be a little bit more willing to undergoing some additional screening for patients who have a high risk. That's one thing. Second thing, okay, this is something, a retinal eye exam can be done in the primary care office. Okay, that's for sure. And it can come now, this has two values. The retinal eye exam actually can confer information about what? About the eye exam, but also can predict cardiovascular disease risk. And guess what? The patients who go to the hospital, the patients who go to the primary care doctors after they go to the hospital, the patients who go to the endocrinologist because of A1C, they are very high risk patients. Okay. So it's really an advantage to their care of those patients to offer to a group that it's a biased group, and definitely you're going to find significant disease at all levels. So you have to screen them. Okay, so having a camera, a camera that is accessible to the staff, and the medical assistant can be trained to use it and take good pictures, and then having this the CVD, being able to calculate the CVD really can help the patients understand the challenges and the complications that are associated with any metabolic disease, especially diabetes. Okay, because that's when, if they know they have disease, guess what? They're going to take care of business. They can aim to be well controlled. They're going to take the statins. If they cannot really tolerate it, they will go to PCSK9 inhibitors. They will take care of business. They will be very compliant. So this risk really, risk assessment helps refines the management at a better level, and I think at a very efficient level. Okay, that not seen until now. So we have done a study here, and we're in the process of publishing it about our in Queens office, Long Island City office. What percentage of patients benefit from doing an eye exam? And guess what? There's definitely, it's in Queens, believe it or not, it's a melting pot, but it's an underserved area. And guess what? African American, Hispanics, high A1Cs, being on certain, lipid, it is associated with worsening retinopathy. Okay, so simple eye exam, very effective, is not expensive. And I have a feeling you're going to start seeing more and more screenings done, even at the level of the hospitals, because a lot of patients, that we stated in the beginning, are not complying with the typical eye exam.
Yeah, I think Dr. Manessis, you have highlighted some of the main challenges that we have going forward. I think one of the issues is increasing the PCP adoption, especially now that better cameras which are more automated. And exactly as you mentioned, any staff member can be taught to use those cameras to acquire those images. So I think one component is the provision of the equipment part. And then the second component is once these clinical care pathways are well established and we are able to, like you just highlighted, highlight which are the groups that can additionally get benefit out of a screening like this. As you mentioned, those who are again traditionally the underserved populations. I think for those groups, this can be really a beneficial tool. And again, one thing again you highlighted was the cost aspect, that its add-ons to the additional care pathways is such small as compared to the potential gains it can have in terms of again quality of life and in terms of catching these potential events earlier. So I think, yeah, that kind of concludes. I think before we go, I would ask you one more clinical relatively question. So, for example, when you see someone has this high retinal rest, do you revise their LDL targets as well? Do you like to go as low as possible with them? Do you kind of try the newer things they say, go as low as possible? Do you try that as well for these
Yes,
patients?
I did try by myself. Sometimes I'm not here. They don't listen to me. But guess what? They're going to listen to a cardiologist. Okay. So, yes, we try to aim for lower, and the patients, they will, eventually will get it, and they will start managing better their lipid profile and the lipid indicators. And, we also refer them to the dietitian, okay, to help them really minimize going on a low fat, low carb, high protein diet. And we have a thing we ask them to do is really to become more active in terms of a lifestyle. And of course, we still have patients who smoke in this country. Okay, and that's smoking cessation is an additional factor that needs to be done. So yes, that's a way of, what, people want evidence-based information. I think most of them want evidence-based information. Okay, and when you give them the evidence, they will listen to you and they will follow you.
Yeah, I think that's probably the best thing that can come out of this conversation that we had with you. That building that evidence base is so critical, and once you present that to the patients in a simplified way that they can easily understand, they do listen to their physicians and they do take the measures to kind of improve their health. And thank you so much, Dr. Meneses. I think talking with you has been an eye opener for us as well. And we are looking forward to some exciting work with you. And especially, I would want to show some of the work that we are going to do together. And we are going to present that at ADA later this year. Would you like to tell us a little bit about that? I know that was a very quick abstract that we did, but just a teaser for people who are listening in.
Being a community endocrine practice, okay, in an underserved area, what we did is we use our retina imaging camera, and we derive a biomarker and traditional ACVD risk score in this population, and that's what we're going to present in a poster abstract permission in the ADA in actually what, 2 months from now? Yeah. So,
Right.
and we get, what, we have more projects, more, posters, more information that we want to present and show how the impact of VI screening, okay, can help us really identify very high risk patients. Okay, because you have to realize there's patients out there who have a low LDL. They're not smokers, but they still have what? They can have atherosclerotic cardiovascular disease. And we're talking about 10% of our worldwide population. And those people, the LDL can be normal, but the lipoprotein A can be high. Okay, so that's another group of patients that we cannot capture with our current screening methods. We can capture with using this cardiovascular model to predict the score, CVD score, and help them identify a disease much earlier before it becomes lethal.
Yeah, I think, Dr. This is exactly what you highlighted, that the traditional tools, even though they are good, there are some patients which are missed. Last year, we were able to show in our work from the MESA cohort that there is a group of people who have zero coronary artery calcium, and the retina is able to risk stratify even in that group. And it is able to show that people who are in the high risk and having zero coronary artery calcium also tend to have events which are higher than the kind of 10% which is used as a cutoff for a lot of these calculators. So thank you so much, Dr. Meneses. And we also have a small library that we have built over time to kind of discuss some of the work that we are doing. So if anyone is listening in and they want to kind of get to know more, you can use the QR code and see our other work. And as per this talk, we are very, very grateful to Dr. Meneses. And as he just mentioned, we have multiple projects in the pipeline that we are going to do together, and hopefully we'll have him back soon. So thank you so much for listening in. Thank you, Dr. Meneses, again for your
Thank you
time.
so much, Dr.
And,
Kapoor. It's my
and,
pleasure. Thank you, guys. Thank you for your work.
and everyone have a good day. See you. Bye bye.